How to help your asthma patient select the best inhaler device whilst weighing up all the important factors. Is it the right drug, cost, ease of use, am I sure how to use it myself, and also environmental impact. I'm Alex Wilkinson, Respiratory Consultant in Stevenage and part of NHSEI Inhaler Experts Working Group, and in this short presentation I'm going to try and help you with this important question. The quality improvement projects in this section are aimed at people with asthma aged 12 years or over, as young people are less likely to be able to use a dry powder inhaler. There are two main types of asthma inhaler devices, metered dose inhalers, MDIs, and dry powder inhalers, DPIs. Metered dose inhalers use hydrofluorocarbons, HFCs, as a propellant gas. These are approximately 1,300 to 3,600 times more potent than carbon dioxide as greenhouse gases. In fact, MDIs alone contribute 4% of the entire NHS carbon footprint and about 13% of the NHS's direct emissions. As part of the NHS commitment to become a net zero health service, we are trying to reduce the carbon footprint from MDI inhalers by at least 50% between 2028 and 2032. This reduction would have a positive effect on climate change and bring us more in line with other European countries that use far fewer MDIs. Not all MDIs have the same carbon footprint. Some contain more powerful gases and so have a higher carbon footprint. An example of that is flutiform, which has a carbon footprint of 37 kilos of carbon dioxide equivalent, whereas Foster is around 12 kilos per inhaler. Other inhalers have a higher carbon footprint because they contain a larger volume of the same propellant. For example, the most commonly used inhaler in the UK, Ventolin Evohaler, has more than twice the carbon footprint, 28 kilograms per device, of some other MDIs such as Salamol and Aeromir. When choosing a device type for a patient with asthma, it's important that this is a decision taken with the patient as part of a shared decision-making process. The most important thing a patient can do for themselves and the planet is to have good asthma control with a device that they can and will use. One of the most important clinical differences between dry powder inhalers and metered dose inhalers is the different inhalation technique they require. Metered dose inhalers, or MDIs, with a pressurized can that sprays the medicine out when you press the canister, and DPIs, which rely on the patient to breathe in hard and fast to get the medicine out of the device. And the different devices each have their pros and cons. MDIs require a slow and steady inhalation over 3 to 5 seconds. They require the patient to be able to reliably press on the canister at the same time as breathing in, although for some drugs breath-actuated devices are available that spray the medicines out during inhalation. And MDIs are best for patients with poor inspiratory flow, for example the very young, the very old, and those with severe disease. They don't always come with a dose counter, which can cause difficulties. Ideally, they should be used with a spacer to optimize delivery into the airways, and they contain powerful greenhouse gases. Their carbon footprint is between 10 and 37 kilograms per device. Dry powder inhalers, by contrast, require a quick and deep inhalation within 2 to 3 seconds. They're good for people with normal inspiratory flow. There is no need to clean the device or use a spacer, which may be more convenient for patients, and they are breath actuated, so no need to coordinate inhalation with actuation, and they have a small carbon footprint, less than 1 kilogram per device. How should we help patients choose the best device? Here's a suggested strategy from NICE, and I like that it highlights probably the two most important factors in device selection. Can you breathe in hard and fast through your inhaler? And can you reliably coordinate pressing and breathing at the same time? And according to your abilities, it advises what inhalers you might like to choose from. Some patients, particularly young children or some elderly patients with severe disease, can struggle to breathe in hard enough to use a dry powder inhaler. Equally, some patients struggle to press the canister or coordinate pressing and inhalation effectively. This is particularly true for those who naturally breathe in hard and fast through the inhaler. These patients would likely do better with a dry powder inhaler or perhaps a breath-actuated device. Observing and assessing patients using their inhaler is vital and can reveal some surprising mistakes like a poor mouth seal or failure to remove the cap. In reality, most asthma patients can be trained to use most asthma devices though, so most patients can be offered a choice of which device they prefer. What inhaler types are we currently using? We learned in an earlier section about the drugs we're currently using to treat asthma and about the widespread over-reliance on reliever MDIs and underuse of controller inhalers. This graph looks at how the types of inhaler device we use has changed over the last 2 decades in the UK. In the year 2000, over 70% of combination inhalers, about 2/3 of steroid inhalers, and 40% of the blue reliever inhalers were dry powder inhalers. Over the subsequent 2 decades, there's been a really dramatic switch to metered dose inhalers for reliever and steroid inhalers. I think this is largely driven by cost, as inhaled corticosteroid ICS and short-acting beta agonist or SABA reliever inhalers have historically been cheaper in MDI form. What this means is that around 2/3 of UK asthma patients have a treatment regime that's over-reliant on blue SABAs, and the vast majority of this SABA is pMDI. This is not good for patient care or for the environment. What do patients prefer? Here's the biggest recent study in which patients were offered a wide choice of different placebo devices to use, were trained to use them, and then asked, which device would you prefer for everyday use? Although there was no clear single standout device winner, multi-dose dry powder inhalers were favoured more often than the other inhaler devices. However, the study included no questions on the environmental impact of inhalers, which I think is increasingly important to patients, even though most patients are actually unaware of the large carbon footprint of MDIs. At the ERS Congress, we heard evidence from over 12,000 asthma patients, and most, 60%, would change inhalers for environmental reasons, and a further 21% said they might. So there is also an appetite amongst asthma patients to consider a different and equally effective device for environmental reasons. Often in clinic, you can spend some time going through the options with the patients, and they come back with a question, yeah, but which one's best? I think this is an entirely reasonable question for a non-expert to ask, and my approach would always be to consider recommending a DPI in these circumstances if the patient can and will use it. They have great real-world evidence in terms of efficacy. Here are some results from a large real-world UK primary care study for asthma patients. The forest plot compares pMDIs, given a default ratio of 1 on the plot, with DPIs and breath-actuated inhalers, BAI. As you can see, the adjusted odds ratio for achieving the composite measures of asthma control and asthma control plus SABA usage are better for DPIs and breath-actuated inhalers. Similarly, the rate ratio for severe exacerbations during the outcome year for patients who received a prescription for their first inhaled corticosteroid was lower for patients using a DPI compared to patients given an MDI or breath-actuated inhaler. Furthermore, DPIs have a lower carbon footprint than MDIs. And as we've discussed, if the full range is offered, DPIs are a highly acceptable device choice with patients. Whichever device you choose, it's vital that you train and assess inhaler technique as well. The first thing to say about inhaler technique is that there's an elephant in the room. Most healthcare professionals don't know how to assess or train inhaler technique correctly. If that's you, then the Asthma UK website is a great resource with educational videos. Very briefly, what are the key steps? Firstly, prepare the device. This may be shaking an MDI or loading the dose of a DPI. Many DPIs need to be held upright when loading, so bear this in mind and explain it to the patient. Breathe out fully. Lift your chin, which is really important to straighten the airway and help the medicine down into the airways. Breathe in at an appropriate speed. Slow and steady for an MDI or soft mist inhaler, such as Respimat, and fast and deep with a DPI. Insufficient inspiratory effort is the most important error with DPIs, so really encourage patients to breathe in hard through their DPIs. Coordination is the most common error with metered dose inhalers. Hold your breath for at least 3 seconds, but ideally longer. And finally, the second dose, which is another common problem, particularly with metered dose inhalers, where patients double puff during one inhalation or they fail to take the second dose at all. It's not enough just to demonstrate technique, though. You have to assess and reassess at every opportunity, because inhaler technique deteriorates over time. This is particularly true for patients who lack motivation, who have poor disease control, and who are using metered dose inhalers. Whistles in placebo inhalers can be very useful for assessing inhaler technique and can be used before prescribing the device. This is particularly important in the era of remote consultations. Some manufacturers provide free inhalation whistles so you can assess and train proper inhalation, and also the patient can practice device handling. Some of these devices will only whistle if the patient has the correct inspiratory flow to use the device. Similarly, for MDIs, there is a tray inhaler whistle that's very useful in clinic and for video demonstrations of inhaler technique. It also whistles only when inspiratory flow is correct. This one contains no propellant but makes a realistic swoosh noise when you press the button and has effectively infinite doses. MDI placebos provided by manufacturers do contain greenhouse gas propellant, but there's becoming less of an excuse, I think, for using them. The patient website asthma.org.uk is also a great resource for directing patients to instructional videos, but they must be used alongside inhaler technique assessment. If you and your patient agree a dry powder inhaler would be the preferred treatment most of the time, but you fear the patient is at risk of severe exacerbations because perhaps they've had them before, then having an emergency rescue pack with a metered dose inhaler and spacer is an option for some patients. And the Primary Care Respiratory Society have some very helpful resources and information leaflets on this. For many asthma patients, DPIs are likely to be as effective during an asthma exacerbation as other delivery methods, though. Here's a systematic review of 23 studies suggesting that a number of DPIs were as effective as MDIs during an exacerbation. If patients struggle to use an MDI correctly when they are stable in clinic, they're likely to struggle even more during an exacerbation. So I don't think giving everyone a SABA MDI is the right strategy. In Northern European countries such as Sweden and Denmark, the majority of reliever medications are DPIs. Another problem with SABA MDIs in the UK is that they lack dose counters, and patients frequently continue using them when empty or nearly empty, resulting in unreliable dosing. In this review, up to 40% of patients believed they were taking their asthma medication when they were actually activating an empty or nearly empty MDI. This is not a problem with DPI relievers, which always have dose counters. Keep in mind, though, that the most important life-saving inhaler in asthma is the one containing a steroid, and it's important to remind patients of this too. So, in conclusion, firstly, we need to select the right drug in the right device for the right patient. At the moment, far too often that is a blue MDI reliever, but according to asthma guidelines, it should be a preventer or combination inhaler. Secondly, make sure you can and do teach and assess patients' inhaler technique. It's vital for effective asthma care. Finally, there are many reasons to choose DPIs in appropriate patients, including patient preferences, real-world clinical evidence, and environmental impact. By choosing the right drug in the right device for the right patient, we can aim to make asthma care better, safer, and greener. Thank you.